Alrighty, we have our very next speaker this morning. I would like to welcome Dr. Aletha Maybank from AMA. Please give her a warm welcome.
Good morning, everyone. Oh my gosh. Good morning. We all got to have some energy here. It's awesome to be here. Thanks for inviting me. I will say I am on my 10th day straight of working and traveling. We had just got off of our annual, we have 2 meetings a year as the American Medical Association, 2 business meetings a year. And so I've been in Washington, D.C. For the past 9 days. So my apologies for sneakers because the heels aren't working anymore post-COVID. And apologies if I'm just a little bit stuck on some of my words. But it's really great to be here in Phoenix and here at this wonderful conference that I've seen grow over the years. So do I just tell somebody the next slide? Or is there a clicker? Oh, I see it. Got it. Thank you. Okay, so part of our equity work, and I'll talk about some definitions around equity. Equity is not a new word anymore for many people, especially post-COVID, or we're still in COVID-ish. But within this time frame, people are familiar with the language, at least, of equity. And here is a land and labor acknowledgement that we have put forward as the Center for Health Equity. Even our Board of Trustees acknowledge and engage with reading the acknowledgement. And we read this not to really acknowledge those whose land we are on as a form of remembrance, but also only as a form of remembrance, but also as a way of unifying us to move forward and forge in a sense of solidarity to create a better future. A lot of equity and action around equity is about centering the people, the voices, the ideas of those who have been most marginalized or excluded within our societies in all aspects of it. And so I want to acknowledge the Thano Otham land that we are on right now and the homeland of those people, as well as the Peeposh today. So this is a book from a book cast. If anybody knows who Ava DuVernay is, she's a filmmaker, has made some big hits, and actually is taking this particular book written by Isabel Wilkerson to film. It's called Origins. But I've read this book many times, and this is one of the quotes that I really value in her writing, that many people may rightly say I had nothing to do with how this is all started. I have nothing to do with the sins of the past. My ancestors never attacked indigenous people, never owned slaves, and yes, not one of us was here when the house was built. Our immediate ancestors may have had nothing to do with it, but we are here, the current occupants of a property with stressed cracks, bowed walls, and fissures built into the foundation. We are the heirs to whatever is right or wrong with it, and we did not erect the uneven pillars or joists, but they are ours to deal with now. And I speak to this because oftentimes people are, while they may be paying attention, they're unclear about their role as it relates to ensuring that everybody has this opportunity to optimal health within this country, that they are outside of it, or that it is the experience of either Black or brown people, women, people who are, have disabilities, that they're outside of that. And they're trying to fix them, or they're trying to fix the opportunities for them, instead of seeing all of us as part of the same community of which we live in this country in particular, but also even the global world. And so I bring that in just to call us all into this space that we all need to be accomplices in thinking through. If we're really interested and we really, really care about the improvement of health of people, then we need to have a different kind of consciousness and a critical consciousness to these issues that exist, or else we're just really all perpetuating harm at the same time. And that's literally what's happening, is the perpetuation of harm because of the lack of consciousness to these inequities that exist, or even caring what they are, or figuring out what to do about it, or asking people how to do it, and in terms of addressing them. And so this is a simple definition of equity. Equity is not only about the outcomes. So a lot of folks will talk about the different health outcomes that are experienced amongst different communities within this country. One of them, and I know there was an event last night, is on maternal mortality. It's well known that Indigenous women and Black women are more likely to die of pregnancy. I live in New York City, and in that city of much wealth, there's much disparity and inequity. And we know within that city, I was deputy commissioner at one point in time of the New York City Department of Health. And at that time, Black women were 12 times more likely to die from childbirth as it related to childbirth. And the reality is it's not just Black women and Indigenous women. All women across this country actually have higher mortality rates and death rates as compared to other nations and other developed nations. So having equity as an outcome is really having the conditions, the opportunities, the power, and the resources to achieve optimal health. And in order to do that, we all have to come from the context of valuing people equally. And everybody will say, of course, I value people equally. You know, that's usually lots of good intention around that. I don't think for the most part, we know there are people who don't value people equally, but I'm gonna say for the most part, people value people equally. But the reality is that our data tells us otherwise. If your data shows up with differences in numbers, we are not valuing people equally, as our systems are not showing up in that way, and the decision makers within those systems are not allowing for that either. And so that's just an honest reality that I feel we have to really come to in the work that we do around equity. It's also looking at the historical context of even how we get here is really critical. And then the resources. Equity, in terms of an action, is all about redistributing resources based on need. That is the action of equity and getting towards equity in the sense of health. So I'm at the American Medical Association, 176 years old, an old institution, considered the largest and one of the most influential physician organizations in the country through its lobbying and advocacy in DC, as well as the state and local levels, but mostly state and federal levels. The way AMA works is that it's really a very democratic governance. They have a board of trustees. They have a House of Delegates, which is representative of all states, as well as all specialties within the field of or space of medicine. So it's called and considered the House of Medicine. So that's where I just came from, the meeting of the House of Medicine from across the country. And they are responsible for creating and establishing policy that the AMA will advocate on behalf of, whether it's at the federal or local level. And I'm on the management team, so I was hired as a subject matter expert to execute on policy that the AMA may pass. And remember, it's a representation of the entire country, so not everyone in the AMA is on the same page. It's like literally like our Congress in that way. And so that's why decisions can come out sometimes that, I feel, or positions can come out in a way that don't fully represent some of the values that we may say we put forward, because I get a lot of that feedback. But that's just kind of the context, because a lot of folks don't really fully understand AMA. It's a very layered organization. I'm still learning it after 4.5 years, but I'm here. So another part of our work is, built into the AMA is that we have these strategic focuses on how we do the work. And so what I'm really going to speak to, you can read on there, some of the specific areas, but I'm really focused on the accelerators that they have around the outside of this circle. And so it was determined by the board and the CEO that we as AMA, equity was going to be an accelerator of our work. So in other words, it's going to be embedded in all that we do so that it accelerates our work to this point in context, again, of optimal health for all. And so it is of note to all business units, not just the Center for Health Equity, not just AR and workforce diversity, because that's what a lot of people think of, DEI, workforce diversity. Equity is beyond that, right? It's what they're doing even in the space of finance. Who are we giving our money to, and who are we contracting with, who are we not contracting with? Equity, IT and communications, all of these are spaces in order to embed equity within our institution. And so I started in April of 2019. There was a policy that was put forward that said by the House that asked for an organizational unit to start and figure out how to embed equity across the United States. This is pre-COVID. And fortunate for AMA, honestly, that they were set up at that moment to be ready when COVID came around because of all the national attention that came as it related to equity. And the organization, there was going to be those expectations from, I think, society at large, but medicine as well, as, what is AMA doing in the space of equity since there was this tremendous exposure. And then there was the public murder of George Floyd also that catapulted the conversation of racism into American society, again, I'll say, as well as within our institutions, when oftentimes we were not allowed to say those words. People were afraid to say those words, very uncomfortable about saying those words, and still uncomfortable about saying the word racism in our society. However, it was a time when we saw a lot of institutions across all kinds of sectors, whether it was health or innovation, technology, making pledges and commitments that they were going to do better to promote racial justice in whatever way that was going to be. And so AMA was not alone in that. The Board of Trustees made this particular pledge, and followed that, our House of Delegates passed policy so that it made actually my work easier after that happens, but policies that actually named racism as a public health threat, also policies around ridding our healthcare system of racial essentialism, really supporting what NIH has told us through the Human Genome Project, that race is not a biological construct, it is a political and social construct. However, it doesn't mean to get rid of race, because we need to understand that the system of racism was created before the idea and concept of race. Racism created the concept of race. And racism, I say, is a system. So to break that down, because sometimes words also are kind of lofty, is a system of power, but also a system that also can oppress. And typically it advantages people who are white in this country and disadvantages anybody who is not white in this country. We know it saps society of its resources tremendously. And so the other part, the third one, which I think is actually the most powerful one, was really ridding race as a proxy for ancestry. So the way that this is exemplified within medicine, there are equations, as an example, clinical equations that exist, and say for kidney function. And for kidney function, pulmonary function, some other things around delivering a baby around pregnancy, there's a race correction. So if you identify as Black, they're going to correct the equations that they use so that you get a different number. And it's all rooted in perceptions and beliefs at a particular time that there was a hierarchy of human value that was based on skin color, a false notion, with white being supreme. And oftentimes, again, not rooted in any type of biology, very much a social construct. And the data shows that oftentimes it held back or excluded Black patients, Asian patients, from getting the care that they needed in the time that they needed. And so there's been a lot of movement over the last 3 years to rid medicine of these race corrections that happen and exist. So another movement that happened, this is from my CEO in 2021. So I talked about 2020. I'm trying to tell the story of how we got here. So now in 2021, as my CEO, I had all the board, I had all the senior vice presidents go through a 2-day racial equity training with Racial Equity Institute. And I'm not saying training alone is enough. This is a mixture of, this action here is a mixture of leadership, commitment, training, as well as accountability. But in reading an article that was written over 10 years ago by the National Medical Association, that was created because Black physicians were excluded from the American Medical Association for over 100 years, and AMA, they came together about 20 years ago to write some pieces together to talk more about the history and the joint history that we have. And so when my boss read these articles, he didn't realize the direct connection and explicit nature that the individual who considered himself, and he was actually a self-proclaimed father of AMA and the founding editor of the Journal of American Medical Association, JAMA, which most people in medicine are familiar with, or health are familiar with. When he realized that he was directly involved in it, he actually, I will never forget getting the email, asked the staff within the building, the maintenance staff, to remove the bus. There was a whole exhibit of Nathan Davis on the floor. He asked for him to remove the whole exhibit and put it in the archives, and that it would be there for educational purpose. But he also realized that it was for folks who knew the history, and especially for those who are Black and brown, but it really should be for anybody, that it was a painful history for AMA, and there was no need to have folks kind of experience that and see that every single time they walk through the hall structures can be harmful, as many of us know. And so that was part of just one step in small movement. So the big movement in 2021, a little bit after that, a few months later, after we had all these policies, we were able to finally release our strategic plan for health equity. And it was quite long. It was 80 pages long, and I always say no strategic plan really should be 80 pages long, but we had to spend the time to really provide terms and concepts so that we could better be on the same page in talking about this work within the space of AMA, but also in healthcare. I came from public health. Public health to me is a little bit more advanced in talking about issues that fully talk about the context of health, whether it's where you live or your home, the car you have, the wealth you hold. Public health addresses those more directly than medicine and healthcare does. And so we needed to kind of evolve this notion about what health was so that we could better understand what it meant to do health equity work. And so one of the pillars that we have is about improving and working with physicians and health systems, those that are connected to the ecosystem of health, all that they knew and their understanding and their learning. And so we have created many tools, and that's what I hear now, is that folks want educational tools. They want tools that they can apply to their institutions to figure out how to embed equity. They want, if you're a physician or a healthcare professional, they want credit to learn about those things. And they want to figure out ways of how you evaluate that over time. And I would say that's probably the space where we're not fully at. There are different folks who have started to step into that space of measuring and evaluating as it relates to getting to health outcomes. But we haven't done enough valuation in terms of, are these tools really working? Are they really meaningful? So a lot of this work over the last, especially 4 years, is making the road as we walk with the experts, in collaboration with experts across the country. And so this is from the AMA Ed Hub. Just of note is that we do have modules about centering equity and digital health. We did this in partnership with UCSF. So if you all want to check that out, and I think I checked all of the QR codes, so they all should be working. Another tool that we have is just around language and the kind of language to use around, just people first, why it matters, equity-focused language. And it's not to, reprimand anybody about the words. I'm not trying to be a word police or anything of that nature. But we do need to have an understanding that sometimes the words and the narratives that they say and tell do impact the decisions that we make. They impact in very big ways. And so I just want to provide one example of, I honor and acknowledge the young people in our spaces. They're really pushing for change. Young people always do, have always done that across generations, and coming up with unique ways of using technology to shape narratives differently. And so this particular one, and if anybody's in health or medicine, when I first saw this, it was actually quite jarring to me. I said, wow, I've never seen a picture in a textbook anywhere of a woman that was Black with a Black fetus. Like, that's profound. Like, almost the majority of our images are of white individuals, and it's just not representative of our country. Forget about all the feelings behind it. The reality is, it doesn't make sense. We're not representing our country in the tools that we're creating and the designing for our country and for the people that are here. So other feedback that I hear, so in addition to the tools, many folks are now looking for, communities to be a part of and to engage with in order to learn from each other what they're doing, how they're doing it. They don't want to replicate or, have to search for too far, to find things that may be working. And so we've launched in partnership with many, and I'll get to the partners in a second, a Rise to Health Coalition. And this we're really not trying to actually create another coalition in a sense, even though that's what it is. We wanted the opportunity, again, to bring together people who are already doing the work and find a platform so that they could share the work that they're doing and elevate and amplify that work across the country. And so we have these 5 pillars that are being organized within this coalition. So if anybody sits with any of these, there are actions, there's a community that is specific to these 5 pillars that are being engaged right now, and it's been growing and growing in popularity over the last year. It actually was finally launched in June of this year, but there's been tons of activation since that time. And again, it just takes you through a path of coordinated and collective action with others. And then these are some of the key partners. And as you can see, there are folks that you've probably heard of Institute for Healthcare Improvements, our core partner. We do have 3 racial justice partners to hold us accountable to that lens, and other lenses of disability and gender as well. But you can see AHIP is on here, Genentech, the American Hospital Association, Commonwealth Fund. So a lot of key players, some regulators are a part of this process. And this coalition, and we're all learning together on what we can do within our respective spaces. So hopefully you sign up. And so then the last part of the conversation is just about the context, another pillar. So I talked about how we're really moving upstream, engaging physicians to understand what it means to talk about structures and systems, what does equity look like, as well as for health systems. The other explicit, and there is intersection between these, is equity and innovation. And one of, I come from public health, and not that there's not innovation in that sense in terms of technology, but our innovation was more so at the intersection of diverse voices, so that we couldn't have innovation unless we engaged with the communities and the neighborhoods that we were serving. That's the point of innovation that we wanted, diverse minds. So not just the health department and the community residents, but also DOT, also Department of Transportation, sorry. Also the business districts. We did major projects of having everyone around the table to provide ideas on how to build a community. That's the diversity or innovation that I'm used to hearing about. So when I come to the healthcare space, it's rooted in capitalism and technology and all these other aspects and realities that I guess they're innovative and they're new ideas, but I feel like oftentimes they're new ideas in silos of individuals and institutions. And oftentimes not even interacting or reflecting the people, well, they may be interested in certain people that they're serving, but not all people. And there wasn't really an interest to really engage all people in the idea and the design creation that I see happening in many of these spaces within health innovation. And then I was getting a lot of reach out from innovators of color saying, they've gotten to this point, they can't get to this point in raising funds. Do you have any ideas? And I'm like, I have no ideas, because I just don't really know this space well, and I'm still kind of learning. So I knew it was important that we had to focus on this area, but I needed to have support and help from many others. So is that KP? Okay, I need new glasses. I need stronger contacts, so it's horrible. But lately, hi KP. So KP's a good friend of mine and a good colleague, and has been really awesome also in providing ideas and context and just support sometimes in doing this work, and institutions have really valued him. And so we started actually an advisory committee, a national advisory committee to inform our direction. And our direction was going to be, as I already elevated, how do we really center the voices, the ideas, the people themselves, so that they're not exploited, into the context of innovation, understand what is needed. Because as I mentioned, in terms of design, we see some evolution now. We're starting to see more interest around AI especially. We see that on the federal administration, really engaging and bringing people together to think about the context of what do standards look like in design. I'm starting to see from AAMC, which is the American Association of Medical Colleges, putting forward competencies and standards in education around equity. The Joint Commission now has a patient safety standard. So there is some development, but the reality is that, in order to drive equity, it has to start from the space of design. It's not you design it and then you bring people in. It's how do you design to make a product that's going to be ultimately amazing, and I guess in the context of where we are, also profitable. That's going to work for the health outcomes of many people across this country. And when we were sitting with the group and the advisory group, it was clear that they felt that we couldn't just go in and say you need to do this, that, and that. But we needed to have a foundation and a set of principles around how to do this work. And these are just elevating the harms that actually are caused by doing innovation in which you are not at the point of design and thinking about equity, or thinking about, and if you don't even use that term, just thinking about how your solution is going to be accessible to many people and more people, not making the assumption that it will be, but actually finding out if it will be, and then actually partnering with people, co-investing with people around the country or globe as well. And so, equitable innovation really focuses on, what's funded, and then also who's funded, and who's funding as well. And we all know that there are tremendous challenges in that reality. So we launched infohealth.org as a way to support elevating principles around what does it mean to do equitable innovation. We already know, that the United States spends lots of money on healthcare and still has some of the worst health outcomes within this country. And we know that, for Black and Indigenous Latinx communities, they experience the worst health outcomes of any within the country. We also know that, in addition to benefiting for patients and communities, that the provision of more equitable health care stands to improve value for those responsible for payment. And so there's a lot of movement, as you all know, towards value-based payment in this country. And so the more our solutions are geared to that, it's actually more aligned with the context of equity as well. And we also know that, people of color and women, those who are other marginalized and people with disabilities, while they comprise almost 70% of the population, they are well underrepresented, as you all know, in the spaces that you navigate doing this work within tech. They are well underrepresented in health solution investment, development, as well as purchasing decisions. And, it's quite unacceptable, but it's not new. I think now, at this point, many of you all have heard this, I would imagine, in the spaces and places that you are. And so, how I end is going to be just that. I'm a believer at this point that data does not move people. Numbers do not move people. It is stories, it's the context of being proximate to people, hearing people's experiences, and just think about your own lives and the reality of that. I can give you a whole bunch of numbers, but it's not going to change who you are and what you do. You have to decide that and have the will to do that to me on your own after I've learned, because even going through these slides, what we know is that you all know all this. People know now that diversity, is helpful for the business and the return of investment. But we also know people are not doing any differently. And the leaders, of funds, companies, and they are predominantly white, and they are predominantly white men. Not only, but predominantly. They aren't doing any differently. And so that's a choice. And to me, it's a choice over not only acknowledging humanity of others and others within this world and country, but amplifying the humanity of others as well. And so, not only, but I am going to give another data slide, even though I don't think it moves you, but I'm going to present something that oftentimes you don't hear. Because I think what's happening now, and I think this is a good movement towards how data is being presented in health, and so we have more dots being connected between health and wealth, right? Health is probably the greatest predictor of your health outcomes within any country and with any part of society. And so now we have more studies. So this is actually led by Michelle Morse, who is Deputy Commissioner and Chief Medical Officer at the New York City Department of Health, who took over from my role after I started the Center for Health Equity there. And she released this is just new from this year, so you can find this online. But really saying, looking at the assets that one has, as well as the types of debts that that households have, that whites still have a longer life expectancy, and they are more likely to have these types of assets and these secured debts. And so there's still budding work that needs to happen with creating these linkages, but we're seeing more of that. Another frame that we're seeing, this is from Andre Perry, who is at the Brookings Institute, and he released the Black Progress Index. This is also within this year, along with Jonathan Rothwell. And on the right-hand side, you can see what he did, and this kind of gets us away from that zero-sum notion that there's not enough resources, et cetera, because it's just not true. But it doesn't compare black to white, it compares black to black. And it looks across cities within the country in which blacks are living longer. Where do they have the longer life expectancy? So if they have a longer life expectancy, what is happening within that community? Why is that happening? And so this is one of the first studies that they've done, and I really feel we need to switch to this asset framing of looking at communities and how people build. But you can see within here, it mentions income, home ownership, and business ownership. So again, in the context of, it's not just about how are the black innovators, the tech developers, behavioral health specialists of color creating solutions, but understand as they create solutions and they have access to capital and wealth, that's better for their health as well. So there's a wraparound in that context. Okay, so I'm not going to go in detail for the principles. There's a QR code, There's a QR code if you want to get it, but you'll have the deck also afterwards. The main principles were just everything that you've heard me say already, kind of dismantling structural racism, sexism, and bias in resource allocation, and you need to start with doing a self-assessment of your organization. What are the metrics that you're going to use to kind of assess and evaluate your ideas over time? Greater investment is needed in health innovations that are developed specifically to improve health and eliminate health inequities. We know this, but also by those who are of the community themselves too. We know that we need better investment models that help support asset ownership. So again, it's not just exploiting, it's not just centering the voices and ideas of people, but it's also how do we co-build wealth as well. And so there are plenty of collaborators, and we did a toolkit alongside of it because people wanted a toolkit on how to do it. So I recommend that if you get the opportunity to check out the toolkit, there are 10 actions that you can take to start that development and that improvement process of what it means to not just advance equity, but actually improve health for all people across this country. That's my call to action. And the only thing I'll say I end with that slide. So the only thing I'll say, I end with this slide. This is the one we end with. It's what I said earlier. I really believe at this point, I've been doing and starting Centers for Health Equity for a long time. This is my third go at it. I do startups within institutions. And I've seen and heard and felt a whole lot of energy and different emotions towards all this kind of work. And I just feel it's about how much we really care. How much do you really care about another human being? That's the bottom line of it. It can be, there's business, but if your thing is business, to me, it's hard. As I do this work more and more, it's quite demoralizing that the only context that somebody would want to be interested to ensure they're not harming another human being is the context of money. Sure, you can figure out all those things. You can get the person who's going to tell you these are the things and this is the business case, which I did a little bit of, but I'm gonna tell you the bottom line about it is it's will. And it's about how you want to show up with other people, which means how you want to show up with yourself and our communities. So that's my talk for you this morning. Thank you for indulging. Appreciate it.